Hello learners, today we will be discussing trauma-informed care and assessments. Trauma-informed care is a way of being. It's a way that we treat one another in the field, and it parallels into the way that we provide care for clients in need. We're going to focus on trauma-informed care concepts and how they relate to assessments. Trauma-informed care asks the question, what has happened to you? It does not ask what is wrong with you. We want to eliminate that language from our vocabulary when working with individuals in the field of addiction, stress, and trauma. SAMHSA has released a concept of trauma and guidance for trauma-informed care approach. This publication was from 2014. You can easily find it online. And the trauma-informed care approach here speaks to how we implement domains of trauma-informed care in our workplace that look like governance and leadership. So concepts here might include having a group of individuals within an agency provide governance and leadership as we implement trauma-informed care into the workplace. As such, we'll be looking to develop policies and procedures that are trauma-informed and use trauma-informed language. Our physical environment in which we work, we need to pay attention here to how our office space is set up. We need to ensure that people have access to leave the room if they need to. We need to make sure that the counselor is staying safe. And overall, we need to make sure that our space is going to ensure confidentiality. We want to talk about engagement and involvement in trauma-informed care. We want all people involved. That includes administrative staff. This is not unique to how counselors should be behaving in the field, but again, how we as a workplace operate and what that means for our quality of client care. The collaboration speaks for itself, and being able to see this social justice and advocacy initiatives from a trauma-informed approach. Our screening, assessment, and treatment services, this is where our focus is going to be today in looking at how we can incorporate trauma-informed care into these aspects of our work. Also, ongoing training and workforce development is going to continue to enhance growth and professional identity, which is trauma-informed care. What about quality assurance measures? How do we know that we're being effective? How do we know that what we have been implementing is actually working? And how do we continue to assess and adapt? And of course, financing and evaluation. With regard to financing, this has a lot of focus, especially in the community, behavioral health, and sustainability. We also look to incorporate more trauma-informed care approaches. We find that employees are more satisfied with their work. We also see client attrition rates decrease because individuals are behaving differently and responding differently and having a more proactive conversation about holistic wellness. And then lastly, evaluation is what we're going to focus on in today's lecture. The sanctuary motto of trauma-informed care was developed by Sandra Bloom. The 4 pillars of a sanctuary-informed practice include knowledge of trauma, adversity, and attachment, values, which include sanctuary commitments, and the sanctuary commitments look like nonviolence, democracy, open communication, and language that we use in our day-to-day work, not only with one another, but the clients that we serve, including self, and we're continuing to assess for safety, emotion, loss, and future. In recognizing with change, there's also loss. So self is a nice way to incorporate a tool into the workforce that can allow employees to explore any safety concerns that are coming up with their current work environment, safety concerns that they have about the individuals in their care, emotions. So what emotions are coming up? How does it impact the culture at work? What loss or change has occurred? That must be identified and discussed in an open communication way where everyone feels safe to explore that. And then ultimately, we want to look at future. We want to be part of the solution. We don't want to get stuck in the problem. So how do we combine these concepts of safety, emotion, loss, and future to develop an informed plan to move forward? Also, there's a sanctuary toolkit that's putting sanctuary into practice in agencies. Also, the sanctuary website has these resources available to you. I would encourage you to take a look at them, advocate about sanctuary informed models, and take these back to your agency and continue to incorporate these skills into the work that you're doing. There is a sanctuary certification available for providers. Not too many individuals who I know have the sanctuary certification. It does take a lot of persistence, and ultimately the administrative tasks seem to be quite a large barrier as far as updating policies and procedures to include trauma-informed language, and that can be a huge overhaul for some agencies. Often it takes a number of people to be on board with reevaluating policies and procedures, and it takes it back to boards that can create a barrier in becoming trauma-informed certified as an agency. However, there are many opportunities out there to still promote these pillars. Additionally, we have mental health first aid available to us in the field. Mental health first aid is a fantastic initiative that helps to train all individuals within agencies and community members on the basic foundations of mental health and mental wellness. It provides trauma-informed response to working with individuals that do have mental health needs. So when we're looking at screening, intake, and gatekeepers, of course, that is our frontline workers. That is often our administrative staff and our support staff. Those individuals who are picking up the phone when people are calling and asking for help. And so what is it that these people are calling, and what is it that they are saying when they're in crisis? We want to ensure that our support staff have the tools that they need to be able to do their job well. We understand that support staff are often not familiar with the depth and breadth of mental health diagnosis, substance use disorders, and trauma in the way that we are educated. So mental health first aid is a very nice way to get information into their hands and make it feasible and realistic to support their jobs, and ultimately to help decrease burnout and allow them to feel more confident in managing these types of calls as they come in and when folks are seeking services. To talk about gatekeeping, oftentimes the individuals who are answering our phones are gatekeepers. They are doing screenings of individuals. So the people that are calling and asking for support or looking to schedule an appointment for a mental health assessment or some form of treatment, they may not always understand what it is that they are trying to achieve. And maybe it's an external motivation that the courts are saying that they need to get treatment, or people are really at a loss as to what type of treatment that they need. So our gatekeepers are asking very informed questions. Are you using mood-altering chemicals? Does that include alcohol? Are you on any medication-assisted treatments? Have you had any hospitalizations? What was the last date of use? What about psychotropic medications or any mental health diagnoses or symptoms that you have had? So they're doing a lot of screening up front. Some intake workers do have protocols in place that are very regimented and provide a script as to what to say, and therefore they can direct people into mental health assessment or a drug and alcohol assessment, or maybe use red flags to show counselors that this person has concurrent conditions present with a traumatic history and is still experiencing some intense emotional health symptoms that need to be addressed, or that this person is currently in crisis and we are working to manage that. So as we look further into these next steps of screening tools, there's a nice way to help gauge where a person needs to go. There are many drug and alcohol screening tools out there, more drug and alcohol screening tools than there are for mental health screening tools. And the drug and alcohol screening tools do seem to be more specific, whereas the mental health screening tools tend to be more broad, looking more at signs and symptoms of mental illness or recent events. So drug and alcohol screening tools We are going to discuss a few here today within the field that are very common. You're likely to have seen these or will see them during your time in the field. The first is the cage. The cage screening tool looks to ask questions. Have you ever tried to cut down your use of chemicals? Has anyone ever annoyed you by criticizing your use? Have you ever felt guilty about your behavior when using, or have you ever used in the morning? So this is the eye opener. This is the first thing in the morning to wake up to reduce the effects of a hangover to be able to function. The cage screening tool can inform us about how much a person is using and look to tolerance and withdraw, and overall, did these behaviors around drug use and alcohol use. As you can see on the other side of the screen, HALT is another screening tool. HALT is the acronym for hungry, angry, lonely, or tired. However, in terms of this screening tool, we're looking to ask, do you use to get high? Are you looking for the effect of feeling yourself chasing the dragon, trying to get that high that you had the very first time? Looking at tolerance, do you sometimes use substances alone? What are the risks associated with tolerance and withdrawal and feeling withdrawn from loved ones or an interest in using alone? Particular risks here include people who are opioid use dependent. With that, often we find that they are using alone, and overdose is a very high risk for them. So we're looking to also understand to provide the appropriate safety net for individuals or naloxone training. The next question, do you find that you're looking forward to using? This indicates a preoccupation with getting high, spending time using the drugs, obtaining the drugs. Do they have a tolerance? Do you find yourself using more frequently? But what about the quality of the drug that you're using, the type of drugs that you're using? What does that look like? Did you initially drink a six-pack and now you find yourself drinking more than that just to function? So HALT is an appropriate screening tool to use. Some of the things that we've mentioned earlier include quality assurance for agencies to know that what we're implementing in the field is working. Here we see the DOS, a drug abuse screening tool. It can either be 10 questions. There's also a 21-item questionnaire available out there. The 10-item questionnaire that you see here seems to be much more palatable for individuals, and it still provides quality information. Also, the DOS can be used as a quality assurance measure that we incorporate throughout the treatment episode. So how do we know the outcomes in our program to see if people are making progress? And maybe this is a tool that we can use. It asks, during the past 12 months, have you experienced these things? But I think that it can be easily adapted to work per quarter, having individuals do this questionnaire once every few months, working with them to see tangible results. And this might also help inform areas where we need to focus on for continued improvement. So some of the questions here are asking about how you use drugs other than those required for medical reasons. Do you use more than one drug at a time? So on and so forth. It looks at tolerance, withdrawal, and substance use disorders. The things that I do like about this drug screening tool is that it uses the word drug. Although this tool, and you can see it there underlined, it is supposed to exclude alcohol and tobacco. I would caution you in doing this. I think that there is much more research and outcome-based information that we need in the field. Alcohol is a drug, tobacco is a drug, and the language that we use from a trauma-informed care approach is going to be very important. We're looking to educate that a drug is a drug is a drug, and we must be looking at our outcomes in the same way. So often it takes a lot of advocacy in the field within our providing agencies as well. So as we work with individuals, we don't want to minimize alcohol use or tobacco use in terms of substance use disorders. But ultimately, as we begin to interpret the outcomes here, you can see the scoring ranges and where an individual might be in terms of the subclinical level, where we would be looking to say they're at a low level, or a low degree of drug-related abuse problems. Therefore, we can conceptualize the case and look to prepare for aftercare planning and closure. If an individual has a severe level and we're seeing this intensive assessment, then we have an intense need that is going to guide us in the level of care that we put that individual in. I do believe that the field is lacking in co-occurring screening tools or assessment tools. There is one co-occurring screening tool that I'm familiar with, but it's quite dated. So I think we have a lot of work to do in terms of advocacy, and there is a potential for improved outcomes in our field. Outside of screening tools, we move to psychosocial assessments. For drug and alcohol assessments, there are many regulatory guidelines that will provide a framework of exactly what needs to be asked in a drug and alcohol assessment. I have seen integrative assessments that include mental health, drug and alcohol, and trauma, but depending upon the program within an agency, they may only require the counselor to complete certain sections of that assessment. So as an example, if you have an integrated assessment that includes mental health, drug and alcohol, and trauma to be part of that outpatient treatment facility, you may only be required as a counselor to complete that mental health component. There are regulatory guidelines that I would check with your supervisor about what that means and how to inform a trauma-informed care approach and how to inform our clinical impressions around any type of co-occurring conditions and ways and means to do that appropriately. I've also said to people, although it's not part of a requirement, I would encourage you to take a look at that and ensure that we are getting all the information to really make sure that we are putting the person on the right track. Chemical use history for drug and alcohol assessments include the following points, such as what types of substances were being used in the past as well as in the present, the frequency of use, how much is being used, the age of first use, the last date of use. Is there an overdose history? Is the individual a survivor of overdose and or a priority population, including people who have overdosed within the last 30 days, specifically because that puts them at acute risk for treatment episodes because they are at acute risk? Here we might be looking at any hospitalizations. Again, that 30-day window is an acute time frame. If individuals were just recently released from a period of incarceration, psychiatric care, inpatient settings, all of those things are going to be important for us to recognize. And treatment episodes also include medication-assisted treatment. We want to be asking, have they had experience with this? And are they interested in learning more? There are regulatory guidelines from some third-party payers that require as part of a drug and alcohol assessment. We are asking medication-assisted treatment questions that we are providing education on these medication-assisted treatments and referring people to those levels of care where they can receive this type of treatment and or ancillary services. So again, check with your provider and your supervisor about those regulatory conditions, but I would always encourage you to ask these specific questions. We also want to know about an individual's period of sobriety. How long was it? What happened when you were able to achieve sobriety for that period of time? What about their recovery environment? An individual might be clean and sober, but be in a recovery environment that is abusive, where they are not feeling safe, there are other people using in the home, there might be prescription drugs available or illicit substances in and out of the home. So it's important for us to recognize what that looks like as part of the drug and alcohol assessment. It's very important to include process addictions such as gambling, sex, overeating. We want to touch base with individuals about other types of addictive behaviors because we will commonly see themes and patterns, and these will inform our treatment and potential goals and objectives that we're working on throughout our time together. Mental health assessments often include a mental health status exam, where there are oftentimes check boxes of how a person presented, like what their hygiene was like, were they oriented to person, place, and time, did they appear disoriented, was there any evidence of poor memory recall or delirium. We're also going to be looking for any type of psychotic symptoms, hallucinations, delusions that may be present for this individual. Again, we're looking at past and present suicidal or homicidal ideation. I would always encourage people to be very direct in asking these questions to ensure that your documentation supports your assessment of the individual in the here and now. It's not uncommon that people have had suicidal ideation in the past or suicidal attempts, so we're gathering data and we're getting that information. But our next step absolutely needs to be, what about the here and now, and documenting those risks and protective factors as part of the assessment. When we're talking about mental health symptoms, it's not uncommon that these particular assessments will have drop-down boxes for anxiety, depression, attention deficit disorder, schizophrenia, for example. And we need to be asking people, when you say you have anxiety, can you tell me more about what that looks like for you, how you experience anxiety? How do you know when you're anxious? What are the signs and symptoms of that? When does anxiety occur for you? How often do you experience it? On a scale from 1 to 10, how intense is it? Where in your body do you find yourself feeling anxious? Sometimes people don't necessarily know how to answer these questions. And again, we can get there if they didn't know. As part of your assessment, you're documenting that the individual does not appear to have awareness of their body cues, although it was explored in the assessment. Making sure that we have appropriate documentation to show that we're doing our work and that we will be able to continue to develop goals in these particular areas. Trauma-informed assessment. Most assessment and diagnosis of a client occurs during the initial intake interview. Most agencies have their standard intake interviews or assessments, all of which have included the things that we have discussed here today. However, the previous elements are essential for accurate diagnosis and provisional diagnosis. They may not be all-inclusive. If the presenting problem is a post-traumatic reaction, these standard clinical screening and assessment tools may miss important information when there is a possibility of trauma-related disturbance. The assessment should consider investigating the following additional components so that we have a clear understanding of symptoms that can be an inclination to a red flag about trauma, their trauma responses, or ongoing disturbances. We're going to be looking to understand intrusive symptoms such as flashbacks, nightmares, or reliving the experience. Are there avoidance symptoms going on? Are people starting to recognize triggers and withdrawing from things that create a trauma response? Hyperarousal, where they're experiencing irregular sleep patterns, decreased sleep, muscle tension, irritability, tension difficulties. Again, this could be a result of trauma. So we want to ensure that, again, we're exploring it so that we're not getting into a position of misdiagnosis or the inappropriate treatment capacity for individuals. Dissociative responses of trauma relate to cognitive disturbances, which may include low self-esteem, helplessness, or hopelessness. And again, this threat of danger, whether that be real or perceived. Tension reduction activities include self-interest behaviors. These might be a way for a person to control their own pain. Perhaps it's activities such as binging and purging. So what do they do to have control over what they're experiencing? It may be a misguided solution to try and control the pain. Transient post-traumatic psychotic reactions, stress-induced cognitive lapses, hallucinations, or delusions. So how do we help people understand their current situation? And for us as clinicians to make informed clinical case conceptualization and clinical recommendations to be able to provide trauma-informed care. There is, of course, a profound interrelatedness of grief and trauma. Loss is the prerequisite for grief, and we know change is loss, and change occurs regularly, fairly constant. So there is always a sense of loss, even in times of positive change. So loss being the prerequisite for grief. What is the treatment for grief? Well, there is no treatment necessarily for grief. It's not a pathological condition. There is a lot of information out there. There's a Grief and Mourning book. It's a very nice resource by J. William Morton. I encourage you to take a look at it. But the purpose of mourning is a way for the body to heal. And we, as trauma-informed counselors, want to start the process of helping people to remember with love instead of pain. How do we integrate trauma loss and get to a place where we are stabilized in the here and now, not allowing that to be a perceived threat in the here and now? Grief can be, of course, very real. It can also be imagined or anticipated. There can be a perceived threat associated with grief, which may look like repression, helplessness, or feelings of bewilderment. Grief and complicated bereavement, as well as mourning, are things for us to be recognizing as part of our trauma-informed care approach. Here you can see this graph. As we start on the right-hand side, the energy levels are increasing when a person is experiencing loss. Then loss is an event. It is a baseline, and from there, the grief process will increase and increasing with energy, creating this crescendo. And the crescendo is looking to the height and the place of a grief process for that individual. So the most severe or the most intense. And here you can see people being very tearful, a lot of anxiety, maybe an inability to function in their day-to-day vocation and responsibilities. As we begin to help people engage in self-regulation and self-rescue, the intensity of this will decrease and they're going to start to desensitize. When people start to desensitize from grief, they're experiencing less tearfulness. They're starting to get back to interests and hobbies and their day-to-day events. However, it might not be where they were before, but they're noticing progress. And it's important for us from a trauma-informed perspective to be talking about their progress that individual is making from a strength-based perspective. We're going to be looking at their coping skills as an asset and helping to grow them in a way that's very informative and meaning for them. As we continue to do the work, we will see people start to reach a recovery process. There are, of course, many common types of losses. We see losses of marriages. We see losses of careers, common health problems. I'd also like to point out that the discontinuation of a substance or a process addiction, those types of behaviors, that's a huge loss. And people will go through a grieving process, and we need to help them explore who they are outside of that change and outside of that loss. When we look at complicated bereavement, here you can see the complicated bereavement will stay in this area of crescendo prior to desensitizing. And over time, if that continues, we might be looking at complicated bereavement situation. And if that occurs, we know that we need to do more intensive work on the complicated bereavement, helping people heal from trauma in different ways. Maybe we're teaching them skills such as debriefing, we're engaging in narrative work, stress inoculation activities, which we'll begin to talk about more in depth. But we need to be mindful of what becomes complicated bereavement and over a period of time. So if we start to see this being an ongoing situation, we need to have our eyes and ears open to that and be able to address it in an intentional way. As individuals look to heal and recover from grief and loss and mourning, recognizing that change is loss. The tasks of mourning include the ability to accept the reality of loss. How do we safely help people from a trauma-informed care perspective explore the reality of this, that it is often a real loss, and that they are feeling something that is very real and very unique to them? How do we begin to move through those bargaining chips and anger and to look at acceptance of the reality of the situation and where we are in the here and now, and again, where we are going in the future? How does that look, and how do we get there? We get there by processing the pain of experience. We do this by integrating the narrative, helping the body to stay relaxed when we are walking through the narrative process so that we can regulate that loss. Ultimately, we move from problem to solution by telling the story of loss. And again, this could be any type of loss, but we encourage the individual to do so by being able to include regulation, self-rescue, deep breathing, as they begin to regulate the loss into the past. We can then move into remembering with love instead of pain today. And that might sound a little odd when we're talking about substance use disorder, but there are lots of things that people will miss when they give up the drug. So it might not necessarily be remembering with love, but remembering that they did have a place, that this was part of their experience, but it is not all-encompassing to their identity and who they are. So maybe we start to explore, how do we now, today, get a natural high? As an example, that includes maybe exercises. What types of interests and hobbies do they have? How can we get back to that? Where can we have a rush and simply feel good because of a release of endorphins in our neuroscience of the body being rewired and yet coming back to this new baseline? We're going to continue to adjust and adapt. That can be externally, internally, and of course from a spiritual framework. And then resiliency looks like finding that enduring connection. What will help us sustain this change? In resolving grief for substance use, that might look like getting to a harm reduction place and then moving into abstinence and stabilization. Not all individuals are just able to stop using in terms of mental health. Not all individuals are just able to never feel anxiety again. So we want to include harm reduction measures. We want to make sure that our interventions are specific, realistic, and that they're measurable. We can do this by maintaining that therapeutic alliance, incorporating relaxation techniques, and using narratives to help integrate and regulate loss. Evaluation of trauma includes a number of scales that look at traumatic events, experiences, and responses. There are a number of scales listed here. They include the Clinical Administered PTSD scale, the CAPS. This is very often used within the VA setting. The Dissociative Experiences scale, the Dissociative Regression scale, Impact of Events scale, revised, the Symptom Checklist 45, Satisfaction with Life scale, and Trauma Recovery scale. All of these tools can be used in a trauma-informed way. Again, they can be part of a screening process. They can be part of a quality assurance process. Perhaps we are using them as outcome measurements within your work for the client or for the agency. So I encourage you to be very mindful about the appropriateness of when you offer such scales. I encourage you to check in with yourself. Don't rely on these scales because you are feeling anxious, or you're feeling imposter syndrome, or you're having self-doubt about your confidence or your ability to work with individuals who have had trauma responses. We don't want to hang on to this paper and allow us to get through this questionnaire. We want to make sure that we are using these scales very intentionally. I've provided you with reading resources for this larger role of the International Association of Trauma Professionals and the Trauma Therapist Toolkit. In that toolkit, all of these scales are listed for you. I encourage you to take a look at that toolkit and become familiar with these scales and think about how you may or may not incorporate them. There's also part of the toolkit examples of psychotrauma evaluation, and in this sample it's written out for you. It is very lengthy, in-depth, and very thorough. Depending upon where you work, perhaps your agency already has a particular assessment already in place. I encourage you to explore that, as well as exploring these other assessments listed on this slide, and maybe find ways as part of advocacy for trauma-informed care to incorporate various different pieces that you think could be meaningful for your work. And with that, I want to end with this continued concept of promoting resiliency. A person may experience grief without trauma, but you cannot experience trauma without grief. It is a constant theme, so we need to recognize how this is interrelated to the work that we're doing. We need to be very mindful and intentional of that as we move through the assessment process. Thank you for your time.